Hello and welcome to Unleashed. I'm your host, Will Bachman, and I am delighted to be here with Amy Parekh. We knew each other way back in the day when we were both business analysts at McKinsey over 2 decades ago, I will say. Amy is the Chief Health Officer at Included Health, which provides personalized health care. We're going to talk about what that means. Amy, welcome to the show.
Thank you so much, Will. And I think you just aged us by
Yes, I
explaining
did.
how long ago we were business
Yes.
analysts at McKinsey, but it's such a pleasure to be back with you. I sort of wish we were traipsing around New York City together while we were recording this, but at least we're on a Zoom and you're still in New York.
Yeah,
So
back on the
that's great.
19th floor, 23rd floor of Park Avenue Plaza.
Yep. Yeah, those memories will stay with us forever.
Okay, so start us off by telling us, just give the longer version of what is the business model? What does Included Health do?
Yeah. So included health, and I've been here for about 6.5 years now, Will. We provide personalized all-in-one healthcare. And so what that means is we partner with self-insured employers and health plans to really change the way that working Americans and their families receive healthcare. So about a third of Fortune 100 companies, about 10 million Americans have access to our services. And what they have is they have one place they can go for anything related to healthcare, whether it's about their mind, their body, or their wallet. So much of healthcare these days is about what does this bill mean? Do I have to pay it? How much is this going to cost me? But also, how do I get to see the best doctor in my network right now? Or hey, can I access a behavioral health specialist for myself or my family in the next week? So we really try to provide access, answers, as well as advocacy as people engage in the healthcare system. So that's what we do. Our team overall is about nearly 3,000 people, but we have about 1,000 clinicians now across the country. These are primary care doctors, these are specialists, these are nurse practitioners, therapists, and they provide care across all 50 states. We also have hundreds of care advocates. These are folks who really understand the ins and outs of how the healthcare system works. So helping you understand, do I need a referral before I see the specialist? How long will I have to wait before I can actually get that MRI? And then about many of our patients come to us because they can't get access to things like primary care and behavioral health. So I don't know if you've had to look for a primary care doctor recently or had to find a therapist or a psychiatrist for you or someone in your family, but across most of this country, it can take about 1 to 2 months to get that type of access. And so we made the decision 3 years ago to not re only rely on the ecosystem as it exists today, but to be a part of the supply problem there too, and really provide direct primary care and behavioral health for patients across the country. So it's a lot. That's why it's all in one.
Okay, so lot to break apart there, and this is a interesting way to kind of understand, and I want to understand how this fits into the broader healthcare system. So one question is, it sounds like part of what you're doing is helping to just patients to navigate the system.
Exactly.
So there'd be like one entity is the payer, one entity is the all the different providers out there, and Included Health might not be the payer or the provider, but someone comes to you and says, "Hey, I have United Healthcare or Aetna or whatever other provider they have, this Blue Cross thing, and so here's my setup. Here's the insurance I have. I have these questions," and you help them navigate, right? You help them get access, but you're not actually providing the direct service. You're helping them navigate that system. That's one piece of what you do.
Precisely. And the way we think of that is we help them navigate the system in a way that is personalized and best for them. So you could like help people navigate the healthcare system and just make them move around in the system that exists, or you could actually be navigating to something better. And we try to navigate you to make sure that you get the best outcomes that you can given the system as it exists today. And so let me break that down a little bit more in detail. So when you are looking for a primary care doctor in your network or a specialist, let's say you're looking for an orthopedic surgeon, we use a lot of data and data science to match you to the highest quality orthopedic surgeon for your need. So if you need a shoulder surgery, we're going to make sure you see somebody who specializes in shoulders versus in knees. And so things like that help us not just navigate within, but really navigate to better. But you're exactly right. We are not a health plan. We're not a payer. We are not, well, we are a provider in part of our business, but we also take advantage of the providers that are in your network. And our job is to help you get the outcomes you so deserve, given that ecosystem.
Now, I'm curious about this part about finding the best provider because that's something that I'm sure every listener, I certainly include myself, have had to navigate to find a provider,
Yep.
right? And online, there is not good sources that I'm aware of the equivalent of Yelp reviews for a restaurant, right? Like you can look, oh, there'll be some best orthopedic surgeons in Toronto, but you always wonder, was that pay to play or, did they just sort of pay to get on that list or something? Or they're just friends of the editor, who knows? And reviews are not very good because most people are not like opting in, like, oh, this mental health therapist was great. They cured me of my depression. Like people don't want to publicly give reviews to, a psychiatrist or something. So, what are the sources of data
Yeah.
that you use that maybe are not available to the general public that to help evaluate who is the best shoulder surgeon in, San Bernardino?
Yeah. So this is a part of the company that I'm just so proud of because it's actually part of why I left sort of traditional medicine to come to the company 7 years ago. So we were the first purchaser of nationally available commercial claims data. And so what that means is, I am a doctor. I think you know that. And so included has all of the claims data that I have ever sort of for any patient I've ever taken care of during my career. So
Oh,
think just this is probably really basic, but anytime a doctor sees a patient, there's usually a claim that is filed of, hey, I need to get paid for this. And so that then comes back. And similarly, if you order labs or tests, all of those things and end up going through a claim system. And so we bought all of that data and we use data science and data models to figure out how do we figure out what actually leads to better care, whether that's in orthopedic surgery, whether that's in cardiology, whether that's in primary care. And we have had some of these models externally validated by a group of Harvard researchers. Their Veracity Analytics was the name of the external firm. But it was all those models based on that data. We supplement this with a few other sources of data. As an example, we actually do use EHR data because we're a provider, so we can do some supplementation there. We run expert medical opinions as a company, so we have some extra data there. But the core source of the data is that universal claims data set that we use to understand physician behavior at the NPI level. And NPI is like the social security number for clinicians.
yeah.
So
At the conceptual level, is that like someone you can see there's a claim for someone goes in for a shoulder surgery and then
you can see, is there another claim because they had to go back for surgery?
right. So you can see like, okay, if they have another surgery like a year later on their shoulder, that's bad. And if they never have another shoulder surgery again, that would be good. Something it's kind of
Yeah,
conceptually.
it's not at the member level, it's at the clinician level. So that's
Yeah.
just but you can also see things like inappropriate prescribing behavior.
Yeah.
So if you think about, obviously now everyone knows opiates can be prescribed and can be addictive. And we were one of the first companies to build a model on that to really look at what predicts inappropriate prescribing behaviors around opiates. But we also built one around benzodiazepines, which now people are starting to talk about, but 5 years ago they weren't, which is another type of medication that can become addictive and that you can see like our providers um, prescribing this at a inappropriate level. Sanctions is a different type of data that's not claims-based that we also use. So we, the thing that's funny in the United States is state medicine is mostly regulated at the state level, not at the federal level. And so every state has its own sanction and its own board of medicine. And so you could actually get sanctioned in one state and then go practice in another state, as an example. So we actually collect all of that sanction data and use it to understand, hey, is this provider someone who's safe for a family member to see? Um, and we have examples of this where people are, they've been sanctioned in 8 states and they're in a ninth state and they're still practicing medicine. And so trying to help people not see those providers.
Question about the quality data, or who is the best shoulder surgeon. How do you get around this issue? And I'm sure this is the most obvious question or objection, but maybe the expert shoulder surgeon might get the most complicated cases, right? That have them because, oh, well, we're going to send that to our super expert, right? So then
Yeah.
maybe they have more complications, but that's because the patients were sicker or harder to treat. Whereas the simple patients who have like the really easy to fix shoulder, they go to the more junior person and say, oh, that person looks good on paper. Nobody comes back. So
Yeah,
how do
you
you,
can tell complexity in claims.
oh, you can.
So complexity actually, like if you think about it, if you think about how payment works, the surgeon who's doing the most complex cases should be also getting paid more. So a simple shoulder is cheaper than a complex shoulder. And so you actually start to see complexity in claims. So that's one. The other thing is, look, data will never be perfect. Like I love data, but it's never perfect. So worst case scenario, if we're not totally sure who's right for like Will's shoulder surgery, you just call one of our clinicians and we help you think it through. Like, here are the pros of this clinician, here's the pros of this is an academic medical center, this is community. Like, there's no perfect, but the data can help you be more informed than you are today. And if you want to talk it through with someone who is like that doctor in your family, like, I don't know, maybe you have a doctor in your family that you call right now who's like, hey, I need to get my shoulder repaired. Can you help me figure out who I should go see? Like,
Yeah.
we can also do it that way. And we use our data to help inform that conversation. But we also will just put someone on the phone with you to have that conversation.
So if someone does not have access to included health, what are the publicly available data sources? If I don't,
I
can't
know.
look in the claims data, what is out there? What
Like,
is available?
everyone should get access to included health.
Right.
Right, that would be the ideal. But no, I think it's a really good question, Will, and I think it's super hard to be a patient in America today and to find that best doctor. A couple of things that are worth doing. And I think people do this today. Because before I started working in included health, people would always, my family and friends would call me as the doctor in their family and be like, Amy, who do I go see? Like somebody has cancer, somebody has this. And I would try my best. And so if you do have somebody who loves you, who is a doctor and works in the system, I always think it's worth a call. The second is most health plans today have some marker of quality that they use, like whether it's like blue distinction is one in the health plan in some of the health plans, there's others. So I think trying to leverage those. CMS has also started publishing sort of their experience with different doctors. Now that's a Medicare population, and this is probably a statement of the obvious, but working Americans and their families do have different primary issues in their health than Medicare patients. Classic example, pregnancy. There's not a lot, there is some pregnancy in Medicare for sure, but not a lot versus in sort of commercial part of healthcare. Pregnancy is a pretty big thing that people go see doctors for. So you kind of have to take the Medicare data with that sort of lens of this is mostly their quality in the older population. So Medicare does things like stars ratings on Medicare Advantage plans. They do look at data on a quality basis. But I will say it's hard. And looking at Yelp and Google, that is people's opinion. And I think it's a good sense of bedside manner, but might not always be reflective of the actual quality of care.
Talk to me about my understanding is that the employers are typically the ones who are paying for
Mhm.
included health, right?
That's right.
So they're already paying for the health plan, and then they're paying for included health as a layer on top of that.
Right.
What are the reasons that employers pay for this? I imagine that they figure in the end it's worth the extra money because saves the employees time, or what are some of the kind of selling points?
Yeah, you started to hit it right on the nail right on the head. So, if you think about it, if you're an employer, you want your employees to be healthy, productive, and engaged members of your workforce. In our case, most of our clients are the purchasers of healthcare. So they also don't want healthcare costs to continue to rise so much
Hmm.
that they can't pay their employees a living wage. They can't invest in other benefits because so much of their dollars are going for healthcare. If you're an employer in America right now, healthcare is sometimes your number two cost after like your supplies. So imagine that you're like a retail business, you're expert in managing supply chain of your retail, and so much of your cost is this thing called healthcare.
Hmm.
And so similarly, it's one of the reasons I joined Included 7 years ago is that I just felt like my mission in life, which is to make healthcare better for people, was so aligned with the incentives of an employer. Like they really do want their employees to be healthy, to be productive, to be able to show up engaged, and they don't want healthcare in America to be unsustainable from a cost perspective, because
Yeah.
they are the ones paying those costs most of the time. So what we've shown with Included Health is that we can give healthy days back to the employees. And so healthy days is our true north metric. We ask everyone that over the last 30 days, how many of you not been able to be healthy because of mental or physical health reasons? You subtract that from 30. And our goal is to improve healthy days in the population. Give people back healthy days. If you give them back healthy days, of course, they'll do things in their lives like go for a walk, hang out with their kids. They'll also probably show up to work better. And then we do that all while you end up saving over time costs on your healthcare total.
Mhm.
And that's why employers pick us.
Yeah, as I'm hearing about it, and by the way, like the reason I wanted to have you on the show is for listeners who are, consultants is something that we might want to mention to our clients, right?
Oh, yeah.
Um, but it sounds like there's a couple different dimensions. So one is that by using a service like Included Health, people, they get the right care the first time. So even though you're paying a little bit more for this extra added layer, if someone only has to get one shoulder surgery instead of two, then you're saving costs. So that's one reason. And the other reason, I mean, and you would think that like the health plan would also be incentivized to offer that sort of support to their patient population because they're paying for it as well. But the other dimension though is just people's time. So if I'm a executive at a company or a worker, direct manager, whatever, and my mom or not my mom, but like let's say my kid has some you know condition and I'm spending like hours trying to navigate the healthcare system, if Included Health can help me like find a provider quickly, that's saving employees time and freeing them up to focus on
The time and hassle factor,
yeah,
right? Like
hassle
it's
factor.
it's time that's not necessarily being productively used. It's being used to deal with this friction we've created.
Hmm.
There was I think I forget what it was. It was a blog or something about a patient with cancer. And she just did like a time study of herself. And she was like, as a patient with cancer, you would think I should be spending most of my time healing, getting better, spending time with my family. She's like, I spend a day a week, literally dealing with is calling insurance companies, making appointments, trying to
Yeah.
figure out the system, just because we've made this system so complicated. Setting up services, like that is where people do end up spending so much of their time. And it's not actually on the healing process or on doing the things you want to do with your life. So that is a big piece of it too. I do think the other piece, and we focus a lot on the navigation side of things,
Yeah.
but is in the service delivery itself. So
All
I
right.
do think employers, and this is where health plans find this very helpful too, is just the access. Like you shouldn't have to wait 2 months to talk to a primary care doctor. If we believe, and I think most people do, that primary care is the key to long-term cost savings in the United States and to better health in the United States, why do we make it so hard for people to find primary care? And similarly, if you're struggling with your mental health, it's it's like we take someone who has like if you have anxiety and then you're trying to call 100 therapists to get in to see a therapist and then none of them can see you for 2 months, you're just making the problem worse. And so I do think employers and health plans also want their members or their employees or their associates to get care quickly.
Hmm.
And we've really struggled as a larger ecosystem to provide that. And I think they see that as a real value add when they purchase our services.
And how do you do that? Like, do you just sort of have internal data that says, okay, here are primary care physicians that currently have some capacity in their schedule, and so that you kind of
No,
know,
we employ them. So
okay,
we have about 1,500 clinicians who work
uh,
for Included Health, either W-2 employees or independent contractors, and they're available. They're licensed in your state, and you can see them virtually. And about half of that is behavioral health provider. So you can get onto the app today. You can say, okay, I want to see a therapist. You have choice. We also know that choice is so important to people. Like you don't want to be like, okay, well, you need somebody and your only choice is Amy. Like you might not want to see Amy. So making sure you have some choices, and then you can schedule like within a week for primary care behavioral health, you'll get an appointment, often within 2 days. But that sort of that is what technology can actually bring to healthcare these days. And so much of what we do as doctors can now be done virtually, and we should take advantage of it and get people access quickly.
talk to me a bit about how what Included Health is doing fits into like broader trends in the industry, other ways that organizations are looking to make things easier to access or to navigate, value-based care. Just like
Yeah.
how does what you're doing fit into the broader picture?
I think the broader picture of American healthcare, and this is definitely being felt right now, is that the costs that we are paying for not great outcomes at the population level is, dare I say, heartbreaking. The cost of healthcare go up. They're going up like these year right now by 7 to 10% year over year. It's like you basically pay for a family of four to buy a car every year, and then you throw it off the bridge, and then you buy another car the next year. That's how much healthcare costs. And that is unsustainable. And so I would say the big trend is that employers who are often the purchasers of this thing that we call healthcare, they need a better solution. They need it so that it's not now it doesn't go from, okay, I was buying a sedan every year, now I have to go buy a SUV every year, and okay, next year we're talking we got to buy like the Jaguars every year.
Mhm.
Like they need healthcare costs to come under control. And so they're trying to do this in lots of ways. They're trying to do it through products and services like ours. They're trying to do it by thinking of like ways to create new networks so that people can access places that do high volumes of certain types of surgeries at a lower cost, perhaps. They're trying to do it by focusing on wellness. So, how do we prevent people from getting sick in the first place? But I think the trend is the purchasers of healthcare, which in America are basically employers and the government. Those are the two big purchasers of healthcare. And then, for some population, the insurance companies themselves are the purchasers. They need something more sustainable. And we fit into that in a couple of ways. One, our services themselves help bring down total cost of care. So that's great. But two, we make it so that we always put the member experience first and can be that place. So if you want to try different things in your ecosystem, like let's say you want to try a different way of delivering pharmacy services, by sort of being that one-stop shop for patients or members, an employer can try different things in the background and not mess up the member experience too much. And so both of those things enable us to sort of um, work with this trend, I guess.
Now, I imagine that your kind of pricing level may be kind of specific and negotiated employer by employer. I'm not sure, but could you talk a little bit about just like the pricing structure and how you set that up? Is it like per head? Does it matter how many employees the person has or what state? Like maybe some states are more expensive. Talk to me about that a little bit.
Yeah, you're exactly right. It's super custom, client by client. Depends on the population. It's not state by state, really. It's really about the population that you're servicing. And often it is based on the entire population because what we want to do is make the entire population healthier. And that means doing a lot for the really sick people and just making sure we're available for the more healthy people. So you don't want to have it cost more just for like sick people. You want it to be even. So we do it mostly at a population level. And then there's sometimes some utilization component, but it is very much a client by client conversation about the pricing. The one thing that I would say is new for us and we're really excited about, it has to do with this transition to value-based care, is we've always put performance guarantees around our payment. Basically, that means like, hey, if you're going to pay us, we're going to guarantee a couple of things. Some are about operation things, like we'll pick up the phone, quickly, and we'll also deliver those savings that I was talking about. But we've actually started participating in shared savings models as of this year as well. And that's in collaboration with CalPERS, the state of California employees and their dependents now have access to our services. And CalPERS really wanted to make sure that they were driving total cost of care savings. As you probably know, a lot of states have a large budget to manage, and those budgets are coming under a lot of pressure. And just like a employer, for a state, a big cost is healthcare for the state employees. And so CalPERS was like, both, we want you to take the risk of if this doesn't go well, you're going to be accountable, but also if it goes well, we want you to participate in the savings. And so that is a new sort of model of pricing as we move more into a value-based payment model over time.
I'm curious, how do payers feel about your service? Are they like, oh, this is awesome because people are navigating the system better, or people, are they like, oh, this is not so good because people are using our services less or something? So
I'm sure
this
it's
benefits
mixed,
my,
like everything.
yeah,
So we do have a lot of health plans that are our clients. So I
of
do,
course.
they're, primarily they purchase us as a virtual provider right now. So they use our virtual behavioral health services, our primary care services, urgent care, because they do need to create access for their members. So
In that case, you're
um,
like another provider.
we're another provider, exactly. But as they sort of build out their provider networks, they really need sort of like access. So we have health plans who are our clients, and I think they like us as their vendor in those situations. There are other health plans that have been really great partners for us. Like we have to be partnered, right? You don't, if you're a person at the end of the day, you want to make sure that the health plan or TPA is partnered with the provider of your navigation services. And depending on the health plan, some health plans, I mean, this is why there's this thing called TPAs, and this might be too jargony, but
What's TPA stand for?
so the TPA, what does it stand for? Oh, that
Third
is a
party
third
agreement?
party administrator.
Administrator.
So they sort of do the core parts of a healthcare function. They can pay claims, they pay them well, but they're not doing some of the added services of a health plan. And so those TPAs love us, right? Because actually, like they do their job, which is play the claims, make sure you're using the network, and we do ours. And so I think most health plans see us as a push to do better. You could argue some of our navigation services might not have been necessary if health plans were doing things differently over the last 50 years. But at the end of the day, I hope whether you're a health plan, whether you're a provider, you should be in this for the member or the patient, person at the end of the day. And I do think these models are how we get to better for patients.
What size of business do you serve? Is it like a
Yeah.
smallest size of business is X number of employees? Is it any size? What's enterprise? What's kind of your focus?
Yeah, we mostly focus on the larger enterprise and jumbo clients. So 33 of the Fortune 100 companies are our clients right now. And we do have smaller clients, and I think they get good results from us. But if you think of where Included has really shined over the last 10 years, it is in those large jumbos. And I think it's primarily because they are purchasing a lot of healthcare.
Mm.
And so they really do need to make sure that they're getting the most out of those dollars.
What's going on with telehealth? During COVID, there was like everything opened up pretty much, and you could do all sorts of stuff via telehealth. And then I haven't followed the news super close, but it seems like some things now are kind of retreated back where they push you more to go back in person. What's the current state of play?
Yeah, I think it's stabilized for sure. That specific example you're using of, hey, it felt like the provider system I went to, and you're in New York, so it could be any of the big players. I used to be able to do anything virtually. I could like see my cardiologist virtually. I could do anything. And now all of a sudden they want me to go in. That's a little bit because of how we have decided to pay for healthcare in this country. They get paid more when you go in person at the end of the day. And they either get paid more. So if it's a state where there's not telehealth parity, they just get paid more for the visit itself, or they get paid more because they can code more because they can do a physical exam and so they can code it at a higher rate, or they get paid more because, hey, if you're at home and I order labs on you, you might go to like an outpatient lab that's pretty cheap. If you come to the hospital or to my clinic and I order labs on you, you're going to get your labs right here, and I will now get paid for those labs too.
Uh,
So there are a lot of incentives for the traditional health systems and providers to bring people back in person from a financial incentive perspective. I don't think we balance that with the patient benefits of virtual. So in this case, I guess I'll use my parents as an example. They've had a lot of health stuff going on. It is like a really hard thing for them to drive to the hospital or clinic. You know, their city, their closest city where they get a lot of their care is San Francisco. Parking in San Francisco is like $35 a day. And they're like stressed the whole time because they're nervous it's going to take them so long to park and they're going to miss their appointment with that specialist. And I bet you they could do a lot more virtually than they are today. But we just haven't incentivized it correctly in this country, I don't think.
oh, okay. So it sounds like it's more driven a bit by financial incentives of the providers and not state law that prohibits
No.
telehealth visits.
Exactly. The only thing on the legal perspective or on the policy perspective that has changed is there was a time where all the states had opened up their boundaries. I don't remember if you remember this, but right in the heart
Mm,
of COVID,
yeah.
because there were such access problems, like I, as a California provider, could see patients in any state. We just assumed I knew what I was doing as a doctor. Those have sort of come back. Like all of the states are doing their own licensing now again, and it's not as open across state borders anymore.
Can't trust those California doctors.
You
Uh,
know.
so talk to me a little bit about the role of AI, what you see happening right now, what things might change over the next year or two in a space like yours about navigating systems or, scheduling calls. Like, will a year
Super
or two
interesting.
years from now, my AI talks to their AI, gets me an appointment, or talk to me about, some of the things that you see in the pipeline.
Yeah, it is really exciting. Well, it's like, having worked in healthcare for over 2 decades now, there are times where I have been jaded. I hate to say it because I'm usually not that type of personality, but you're like, oh my gosh, I've been working so hard to make this healthcare system better. Is it going to get better? And AI has given me a lot of hope in the last 6 months because finally there's a tool that can actually take some of the work off of the healthcare workers, right? We have a shortage. We can't seem to give people enough access, and this tool is incredible. I mean, I don't know if you've used it for your own healthcare, but most people have. Like, I think 20% of conversations with like maybe even higher with ChatGPT and all of these tools are healthcare related. People are using it. And they're using it for therapy type things. They're using it to diagnose, like to figure out, do I need to be worried? Do I not need to be worried? And so that type of access is unbelievable. Now we have to get it right. Like it scares me sometimes. The hallucinations are real. Like you shouldn't take everything it says. You want to check with a real doctor sometimes. But maybe the access is the key here. It's that will unlock so much more than and then we'll get it right. So I'm at the highest level, I'm very excited for what AI can do in healthcare. Places where we as a company are already using it, to your on the navigation side, to your point, like really, if you think of, I don't know if you've ever had to read a plan document, but these are really complicated. It's
Mm,
like, where do you have to go for what? How much will it cost? What, like all of that, that's so hard for a human to like always get right.
mm,
So easy for AI to get right, to like help you calculate your deductible, understand what something's going to cost. And so we have invested a lot in using a member-facing AI first tool. It's called Dot. And Dot can answer most of your sort of basic health insurance type questions. What's my deductible? How much is like all of that stuff? And so that's really great. What we think is unique to us is we're always backed by humans. So I don't know if you've ever been in a horrible chat situation where you just can't get out of it and you're just talking to the algorithm or the AI and you're like, this is horrible. I need to talk to a human. We back all of our AI up with humans, and whether that's on the clinical side or on the care team side, Because we think that it's like you need the AI and then you need the EQ of the humans, and that's how you ultimately get the outcomes we want. So I don't think AI only is the place we're going to end up in healthcare. I think it'll be AI that's both supporting the humans who are doing the hard work of taking care of people and making their jobs a little bit easier so that they can do more for the members.
Amazing. Amy, for listeners who wanted to learn more about included health, where would you point them online?
I think you should go to our website, includedhealth.com, and you can learn more about us.
Fantastic. Amy, thank you so much for joining today.
Well, thank you so much. And at some point, we'll have to go back to some bar we went to in New York and grab a drink.
Sounds good.